Welcome to ATCM, the Emergency Medicine channel. Today we'll be discussing an acute emergency case that was presented to our ear. A 52-year-old female, status post spine surgery, around 3.5 weeks back, was brought to our ER with a history of acute onset breathlessness for the last 8 to 12 hours. So, initial 10-second assessment, patient was conscious and speaking relevantly, but the patient was very much tachypneic. She was triaged to the red area, and we connected her to the monitors, and she was kept in a propped up position. And by the time the arrangement for an supplemental oxygen was initiated, her airway, we went with the parallel assessment of the primary survey. Her airway was patent. There was no signs of airway compromise like pooling of secretion, hoarseness of voice, gurgling sound, and there was no stridor or any other airway compromise at this point. Her breathing, she was maintaining a saturation of 76% in room air. So initially she was started on a supplemental oxygen with a face mask at a 10 liter of supplemental oxygen was started.
What type of face mask?
Sun
mask, non-rebreathing mask?
Normal Hudson mask, not an NRBM. Then her workup breathing was, increased workup breathing was there. She had a respiratory rate of around 28 per minute. Air entry was bilaterally equal. Bilateral chest movements were there, and bilateral crepitations, diffuse crepitations were present. There was no wheeze.
Accessory muscles?
Use of accessory muscles was there, increased workup breathing, with the use of the sternocleidomastoid and fast breathing, sir. But with the supplemental oxygen, her saturation has improved to 96% with the 10 liter O2, and her respiratory effort was also improving.
What is baseline CO2?
76%, sir.
Room air.
Room air. So, we at that point we are all as a adjunct to primary survey, we had asked for an arterial blood gas also, sir. But the blood gas was taken after initiating her on O2. We went to a circulation part. Her pulse rate was 128 beats per minute. It was regular in rhythm, and she had a blood pressure of 70/50 millimeters of mercury. And at this point, two large bore IV cannulas was inserted, and a fluid bolus of 5 ml per kg. That's around 250 ml was given to check for fluid response immediately.
Why it was decided for 5 ml per kg?
Sir, as a fluid response in a fluid challenge, we give 5 ml per kg, around 250 ml bolus was given, because she is having breathlessness, creps are there, and hypotension. We don't know her cardiac status. So if she is improving with that, by the time only we can get a echo done, to know her cardiac status.
What was the echoing status? It was distended, or maybe due to hypotension you are not able to visualize. Okay, so IVC.
After that we checked the IVC, sir. So IVC was 1.9 centimeter with a less than 50% collapsibility. It was more full only, without any respiratory variation.
Okay.
What
was the peripheral pulses? Dorsalis pedis, whether it was a warm or cold?
Her extremities were cold, sir, and peripheral pulses, dorsalis pedis was not palpable initially, sir.
Suppose this patient has got a warm peripheries instead of cold, what will you suspect?
Distributive shock.
Any anaphylaxis and all those things.
Because of most common one.
Anaphylaxis.
Most common is septic shock. A post-operative patient that is coming to you with breathlessness, you cannot think n number of possibilities, but here it is cold. But when you see warm shock, you have to definitely think of a distributive shock. So distributive shock, among them, the most common will be septic shock and anaphylactic shock. And anaphylaxis, unlikely, there is no trigger in this patient. Sepsis can be a possibility, but here it was cold peripheries. So cold peripheries, then how will you differentiate between whether it is hypovolemic or cardiogenic? It can be hypovolemic or cardiogenic.
So we can look for the volume status. EC method is a bedside ultrasound using IVC we can check for, sir. If the IVC collapsibility index is a more dynamic parameter. So if the patient is having a hypovolemia, the patient's IVC will be like having a respiratory variation more than 50%. Then
if you don't have an ultrasound.
Passive leg raising test.
So passive leg raising test. How will you do a passive leg raising test?
We have to elevate the lower limb of the patient at around 45 degrees for like 2 to 3 seconds, and then
2 to 3 seconds?
No, 2 to 3 minutes.
Yes.
2 to 3 minutes, and after that, if the patient's systolic BP is improving,
it is similar to a fluid challenge test. Rather than lifting the patient's leg, if you are able to move the patient's bed, we are able to do the turnover. That is the best. Rather than we holding it and moving. In this patient, it's a recent spine surgery, so we will not be preferring that. But it is just similar to your fluid challenge. You said 250 ml fluid you wanted to give and see. But the same thing when you do this, you can have a 250 ml of nearly approximately 250 ml of fluid challenge. Similar to that fluid challenge test we can do, and you can see an improvement in your systolic. Usually, what will be the pattern of improvement? We can have an increase of 10 mm of Hg. That's a usual thing with the fluid response. So then you can easily give fluid without any doubt. You can do maybe if you don't have an ultrasound. That was the one option that you can do is the passive straight leg raising test. Passive leg raising test, not straight leg, passive leg raising test.
And with that. The circulation part we had like given a fluid challenge, but her BP was not improving with that, and since her IVC was also like full, we had started her on noradrenaline infusion, sir. At this point, to maintain a map of like more than 6%.
So what type of shock you are suspecting for her?
Basically, sir, it mostly can be a cardiogenic shock because she is having a cold shock and her IVC is full, so mostly it's a cardiogenic shock. The ideal choice of drug is a inotropic agent, but if we started dovitamin or something, her BP will further decrease. So initially we'll put her on NORAD, increase the BP, and then we can plan on.
Okay. So dovitamin has got its beta effect and it has got also its alpha effect. Alpha effect, it causes its vasodilation. So depending upon your systolic BP, you can decide the choice of vasopressor initially. 90 systolic you can take as the cutoff. Below 90, like this patient is 70, so build up with noradrenaline and then you add dovitamin when the BP goes above 90. So why not dopamine?
Her heart rate was already 128 per minute. Like the tachycardia will be there. If the tachycardia is worsening, the filling will reduce and further the hypotension.
And again, the chance of arrhythmia will be more. When you give dopamine, that's a comparatively evidences have shown that dopamine has got higher the chance of causing arrhythmias when compared with noradrenaline. So noradrenaline, technically speaking, when you theoretically it will cause vasoconstriction, but still it will not cause a coronary vasoconstriction. So you can give noradrenaline, then improve the BP, then you add dopamine. So we added noradrenaline to this patient.
With that, her BP later. There's a parallel assessment. So her disability, GCS was 15 on 15 and her GRBS check was 180 milligram per deciliter. And coming to the exposure part, her temperature was 99 degrees Fahrenheit axillary temperature. If we will take it a correction factor, it will be like around 100. So already she's having a tachycardia also. We had given her an antipyretic. 15 mg per kg paracetamol. Here we had given her IV because she was on mask and this, so we went for IV paracetamol.
Cardiac failure. You are having a cardiac failure with hypertension.
Metabolic rate should be
IV.
With this, we again reassessed the primary.
ABG, what is?
ABG was showing a metabolic acidosis, that is lactic acidosis.
Just tell the values initially.
Her first ABG was showing a pH of 7.356 with a lactate of 7.8 and a PCO2 of 25.4 and bicarb of 13.9. So it is a compensated metabolic acidosis because
expected PCO2
is 29 plus or minus 2.
What is the?
It is 25.4.
25.4.
So metabolic acidosis with a respiratory alkalosis, small component respiratory alkalosis.
Okay.
Then her PaO2 was 79.5.
That is after supplemental oxygen.
It was initially on starting supplemental oxygen. So and her SO2 was 93.3.
93. Matches your ABG. It matches your saturation also. Anion gap?
Anion gap initially was 12.2.
12.2? Can you just calculate that?
169, 103, 116 minus 130, 13.
Okay. It's a high anion gap. It's a high anion gap. Lactic
acidosis.
maybe the sodium in the blood gas we will not be able to say it correctly. Maybe the sodium value is wrong. It is usually a high anion gap metabolic acidosis. That's what you see in lactic acidosis. Why there is lactic acidosis?
So hypoperfusion will be there. The hypoxia was there. And all these can lead to lactic acidosis.
Lactic acidosis, okay. So what will be the type of lactic acidosis? It will be in
Type A.
Type A lactic acidosis. Okay.
Hypoxia is also there.
Also, so it can be combination. Okay.
With this, we reassess the primary survey. Her airway was
ECG.
Yeah. Adjuncts, like we have asked for three adjuncts. One is ABG, second is ECG, and third is chest X-ray, and also bedside echo was done. So ECG was showing a sinus tachycardia, and there was no acute STT changes or no other significant abnormalities in the ECG. Sir.
So just ST segment, no ST segment changes, just tachycardia. 120 was the heart rate.
128 was the heart rate. And chest X-ray was a portable X-ray was asked for. It was showing bilateral infiltrate with a large predominant involvement of the right side. It was like diffusely involved and
suggestive of pulmonary edema, or what you feel?
Not typical pulmonary edema. It's more like a pneumonia like picture. Bilateral involvement.
Bilateral, right more than left. So what is the difference between an X-ray finding in a pneumonia and a pulmonary edema? So how will you differentiate it? Whether you will say it's a bilateral pneumonia, how will you say it is pulmonary edema?
Peripherally, like pulmonary edema, there will be the increased
the classical bat-wing appearance. So prominence from the hilum, when you see it as a bat-wing. From the hilum, it will be expanding and it will be a homogeneous opacity. That's a usual thing. And after some time, once you give the treatment, the clearance, everything will happen. Air bronchograms can happen in a pulmonary pneumonia, but it's a higher. Rather than you will have the curly A, curly B lines and your bat-wing appearance. When you say bilateral pneumonia, it can be a bilateral consolidation also. It is difficult to differentiate sometimes, but it will be more in the periphery. It will be involving almost all part of the lung. And again, air bronchograms you might be able to see in your X-rays. So here, what was your suggestion? It was more in favor of?
It was like a bilateral, not a like central. Basically,
maybe again with the position of the X-ray, what you have taken. So it might be due to the exposure part. With the rotation of the film, everything will be difficult to assess. Okay.
Then other thing was a bedside echo was done. The echo was showing basically RV dilatation was because the RV size and the LV size was like RV was more than the LV. When we checked for the apical view, the RV was more than the LV.
So RV dilatation with the RV dysfunction features.
Okay. We had given an emergency cardiology consultation for a detailed echo and evaluation at this time.
Sir, anything, sir?
What is the build of the patient?
She is like moderately built only, sir, not an obese lady. Moderately.
What was surgery done?
It was a D6, D7 laminectomy surgery with the excision of a extramedullary mass, like a Psammomatosis meningioma.
How long back she underwent the surgery?
Around 27 days. 27
How many days she was bedridden?
After that, after 1 week, within 1 week she was mobilized. She was started to mobilize.
She was started to mobilize by the doctor, whether she was getting mobile or she was in the bed.
But in the house, she was mostly, her activities were restricted in the bed only. But she was not on any catheter or anything. But that too, they had given her the bedside fans and all. So her weight and activity has come down.
Menopausal period?
She is like perimenopausal, 52 years. Attained menopause.
Contraceptive
hormone. No.
Why these questions? Build of the patient, OCPs.
So basically, all these things are risk factors for a pulmonary embolism or a hypercoagulable state.
Okay.
So after the our primary assessment,
So we have an 52-year-old female who came with an hypoxia, hypotension, tachycardia with features of cardiogenic shock. That is our history, and you evaluated them, and you started her on oxygen with a face mask, 10 liters face mask. The saturation improved, and an noradrenaline was started for hypertension. Before that, you give a fluid challenge of 250 ml. Later on, with your non-invasive monitoring, you found out that the it is IVC is not collapsible and it is not compressible. So fluid, we avoided the fluid, started on noradrenaline, and we improved the BP. Meanwhile, an ECG was taken which was showing a sinus tachycardia, and echo, a bedside echo was done which was showing an RA-RV dilatation. So with this background history, we are almost certain that this is the diagnosis.
Our first diagnosis was to rule out a pulmonary embolism, sir. Because when we checked for the well score, the well score was coming to 4 only, sir. But 4 according to no guidelines, less than 4 is less than or equal to 4 is P unlikely. But this history was more suggestive.
PRC.
Rule of pulmonary embolism rule of criteria. She had if at least one is there, we have to take pulmonary embolism into consideration. So she had SpO2 less than 95%, heart rate more than 100, and surgery or immobilization in last 4 weeks. So basically, PRC, what we can remember is by the mnemonic of heart clot. H is hormones, that is can be OCP intake or any other hormonal intake. Then A is active malignancy. D is the DVT or pulmonary embolism in the previous history. C is coughing up blood, that is any hemoptysis. L is leg swelling. O oxygenation, SpO2 less than 95. T is heart tachycardia, heart rate more than 100, and S is surgery or any immobilization in 4 weeks. So she had a high risk.
This is a straightforward because she has recent surgery. She was immobilized and she has come with an unexplained hypotension and unexplained tachycardia. Definitely, we have to look in terms of pulmonary embolism. But very much time, what will happen? We will miss this. That's the usual scenario because there will be no major risk factors. Here, the first differential is pulmonary embolism. Without any doubt, we can say it is pulmonary embolism. That's the first differential.
And second thing, fever, it can be secondary to the pulmonary embolism itself, or is surgery and bed rest, she may be having reduced diaphragm movement, chance of atelectasis, consolidation and all are there. So we had checked for the complete blood count and the infection markers.
What are the common ECG findings? Many of them have got idea that all pulmonary embolism should have this S1, Q3, T3. What is your take on it?
The most common finding in a pulmonary embolism is a sinus tachycardia. Then if there is severe RV dysfunction and all, there will be features right bundle and block white QRS with the RS pattern. Then there can be a RV strain pattern, that is T inversions in V1 to V3 and also in the inferior leads 2-3 areas. The S1, Q3, T3 it is not very much sensitive or specific. It can be there in some 20%.
20 to 30%. 30% is the maximum that you can see. And seeing S1, Q3, T3, you can't say it is pulmonary embolism. But a pulmonary embolism patient might have an S1, Q3, T3 very easily. That is the only significance of it. And what is the sign called as? McGinn-White sign. So that is the name of the sign. McGinn-White sign. Just for the sake of confusion. What is the classical X-ray finding? Hardly we will see the X-ray finding.
It is the Hampton sum is one thing. That is the wedge-shaped opacity due to pulmonary infarction. That from the pleura, a wedge-shaped opacity will be there. Another thing is the Westermann sign. That is due to oligemia. From after the thrombi, there won't be blood flow. Oligemia, because of that, changes will be there. These are the common X-ray findings. That is same.
So, how will you approach a patient with suspected pulmonary embolism in the ED? This is an unstable case. So, suppose you have a stable and an unstable. So, can you just elaborate the management aspects?
If it is a hemodynamic unstable patient, that is with the hypotension, ideally this hypotension not improving with the inotrops and all. Severe respiratory distress, all these things patient will come into hemodynamic unstable. So the treatment is ideally the thrombolysis, and the investigation that can be done is like the patient is.
You need a confirmatory test. You need to have to confirm that this is pulmonary embolism. So for an unstable victim, what you have done in this patient?
This patient, like a bedside echo was done. This is showing a RV dysfunction. We can also go for a bedside DVT screening can be done.
Bedside echo, what all the findings that is suggestive of a pulmonary embolism? One is the classical RIR dilatation. Sometimes in the proximal thrombi you might be able to see. Then
tricuspid regurgitation is one thing. Acute pulmonary embolism, that can be TR. Then one thing is the McConnell sign, which means the hyperkinetic effect.
Hyperkinetic effects, but that's all very rarely we have seen. But the most important thing, RV dilatation, suggesting RV dysfunction, we'll be able to see. So this patient would have developed an RIRV dilatation, and on top of that RV dysfunction, which went on into an LV dysfunction and failure and hypotension. Otherwise, with just an RV dysfunction, she should not have hypotension. So RIRV dilatation went on with an cardiac left ventricular failure also. Then she developed the hypotension. So, what are the major blood pressure? How the blood pressure is maintained in her body? Why she is having hypotension? This is
that is the LV filling time. Because of RV dilatation, the R will be pushed into the LV. So the LV, that space will be like reduced. Because of that, cardiac output will be low, and that is why she is having a hypotension.
See, either you can have the pump, or you can have problem in the vessels. So you have a decrease in the systemic vascular resistance. Again, that is happening in your septic shock. So we have a lot of pooling of blood in the periphery. So you give a vasoconstrictor and you get back to the blood. So increase the venous return. So that is how we have to manage this. So here it is a pump failure. So due to a pulmonary embolism, it is more in favor of an obstructive shock. So that is a category that it will come in. Pulmonary embolism is hypotension. For a stable patient, what will you do?
For a stable patient, we can go for based on the well score. If it is like highly suspected, or
we are having a high suspected pulmonary
if it is like then we can go for a definitive imaging. CTPA can be done to.
So investigation of choice is CT pulmonary angiogram. If you have a facility, go ahead with CT pulmonary angiogram. That is conclusive. You know the vessels, you image the vessels properly, and you see where is the problem. So that is clear. CTPA. Then what are the other options?
If there is contraindication for CTPA, like renal dysfunction or anything, we can go for ventilation perfusion. Scanning can be done. If there is like perfusion issue is there, then we can suspect a pulmonary.
Where will you not have much use with doing a VQ scan? In which scenario VQ scan will not yield you a major result? Recurrent pulmonary embolism. Already there was a pulmonary embolism previously. Now we do again a VQ scan. We are not very sure it was due to the previous one. Unless and until you are doing it in the same center and you have the same images available, it is difficult to compare with the old. So it's a recurrent thromboembolism, it is difficult. So investigation of choice is CTPA. There is no doubt CTPA. You can look for the vessels and where is the input. Otherwise you go for the ventilation perfusion scan. Can you just tell me what is the role of D-dimer?
D-dimer, like it is used as a negative predictive value. Like
do you want to send a D-dimer in this patient?
This patient, a D-dimer can be sent. So like if it is.
Do you really want a D-dimer?
No, here it is not indicated, sir. But if we have it's a low probability. We have a doubt of that. If D-dimer is negative, we can say there is no embolism. But D-dimer positive can be due to a number of causes.
So when you have a high index of suspicion, definitely it will be positive. And when you have a low index of suspicion and then you are getting a negative D-dimer, it has got some value. So that is the only value.
Predictive value is only there. So this patient, after like initial stabilization, we repeated her ABG after like around 1 hour, which had showed improvement. Her pH had become 7.4 with the bicarb 16.8, and her lactate had come down to 3, and also her PO2 was 97.2. And with like around 8 liter oxygen, she was maintaining saturation of around 98, which we were titrating the oxygen accordingly, and her tachypnea had settled and she was feeling better. So with that thing, we had also sent for other routine lab tests. So she.
Sir, anything, sir? anything to
See, any comorbidities we will not mention.
Sir, this lady, she is a diabetic on OHS, sir. No other previous history of any hypertension, dyslipidemia and all. Her malignancy is a meningioma. Status goes with surgery. She has attained her menopause and not on any other medications like hormone replacement therapy or nothing like that. No previous history of any other malignancy, no hypothyroidism. Then she was like only the history after surgery, only immobilization, everything was there. Before that she was active.
Perioperative anticoagulants,
uh,
or she getting any low molecular weight heparin.
post-operative perioperative?
in hospital was there, so, but after that she was not on anything, and she was mobilized also from.
A catheterized patient.
No.
During operation.
During operation she was
post-op.
post-operative initial period she was catheterized, but when she was sent home she was completely mobilized and off catheter.
The most important thing in this patient, what would have prevented if that clear-cut instruction would have not been passed. Maybe after going home, they would have some pain and they would have stopped their activity, and which would have precipitated this event by causing a DVT, which precipitated into a pulmonary embolism. That might be the reason for this patient. Now, let's come. We have made a diagnosis. Know how to proceed.
Okay, so this patient pulmonary embolism, we didn't go for a thrombolysis because her BP everything was improving, and also this saturation was improving. One thing we didn't go for a thrombolysis was her history of a recent spine surgery. So actually the absolute contraindications for thrombolysis is any hemorrhagic stroke, any acute ischemic stroke in like 3 months, any active bleeding, then any intracranial surgery, intracranial neoplasm, and
So
all.
the only reason why we didn't, she's a candidate for thrombolysis.
Ah.
Why didn't thrombolysis was?
Closed
Due to the recent spine surgery.
surgery.
Now, what will be the indications for thrombolysis?
One thing is cardiac arrest due to pulmonary embolism. Then hemodynamically unstable patient, that is any hypotension with systolic BP less than 90 or decrease in more than 40% from the baseline of systolic BP. When on echo we are seeing a large thrombi, right atrial or ventricular thrombi. Basically, if the patient is having a unstable, we will do. Otherwise, we can grade it to an intermediate risk patient. And if it is an intermediate risk patient, we can check for pulmonary embolism severity index. And if the pulmonary embolism severity index is high, then it will be a intermediate high risk patient. And if such a patient is developing, there is high chance of going into a collapse. So if such a patient is having a hemodynamic instability, we will have to suddenly go for a thrombolysis.
Previously, it was like when you have an elevated cardiac enzymes, RIRB dilatation, all those group of patients, thrombolysis was suggested. Nowadays, it is very clear with cardiac arrest, with hypotension, and again, as you mentioned, intermediate high risk group of patients. After doing your pulmonary risk stratification, you can think of thrombolysis, and agent of choice is PPA, and plasma inoculated dose.
100 units we can give it as
100 mg.
100 initial 10 bolus and later over 2 hours
as an infusion.
So that is the choice of that. It's not available in in primary setting. Even streptokinase can be used.
But the approved one is
FDA
approved one is
TPS.
tissue plasminogen activator ultimates. Then once you have decided to because in this patient you have not done thrombolysis. No. So what are the other options?
So we have gone for anticoagulation, sir. So anticoagulation, we started her on heparin. Unfractioned heparin infusion was started for her. So
can you tell the dosing?
It is 80 unit per kg initial dose followed by 18 unit per kg infusion. 80
as bolus followed by 18 per hour as infusion.
And we have to check the target is APTT values around the 1.5 times the normal.
1.5 to 2 times the APTT value.
So we have to monitor the APTT every 6 hours. And if after the 6th hour, if the APTT value is less than 35, then we have to again give a bolus and increase the infusion by around 4 units. Then if it is 35 to 45, then it is 40 units per kg again bolus with the increase in infusion by around 2. if it is like 45 to 75, no change in infusion. If it is 75 to 90, we can decrease by 2, and if it is like more than 90, we can stop the infusion for 1 hour and then decrease the infusion and restart it.
So the idea is our target APTT is 1.5 to 2 times. Why is 35? You taken 35 as a normal one. So 35 normal, 45 approximately you have taken as 1.5, and 70 is the double. So between that is our target. So if you are achieving that, you continue the same way. If you are not achieving that, then you need to increase. So depending upon the scenario, we need to sometimes double the infusion, or maybe half the infusion, whatever you are given as bolus you need to give. And if it is very high, you need to sometimes stop the infusion. That is a basic criteria. There is no need to bypass this. We can chart this because it depends upon the patient's weight. So if you are starting on an heparin infusion, we need to have this in the case sheet. So hourly what to be done for your heparin infusion, not insulin, heparin infusion.
And other thing is,
why you want to do big deal with doing an heparin infusion? You can do straight away with low molecular weight
heparin can also be given, sir. Here the patient, her renal function was also fine only. It was here first value is 1.65. This first
maybe due to hypotension.
Yes, sir, but our ABG value of creat was all fine only, around that range only.
So only problem is that the cost factor. But when you compare the number of times that you need to check APTT, comparing that the comfort of the patient, the cost factor will be the same for your low molecular weight heparin. So if you are planning low molecular heparin, what is the dose?
It is 1.5 units per kg as a BD dose.
Then what you have to start simultaneously?
Like warfarin, vitamin K antagonist, like warfarin can be started. If we are going for like then apixaban, then there is no need of a bridging thing. Otherwise, we'll have to start warfarin, check the INR every daily, and the INR target should be like around 2 to 2.5 like that. Till then, we'll have to continue the heparin. Then after that we can stop that.
Only thing is that problem is with warfarin, it will take time to act. It will take at least 1 week for it to come. So you start around 6 mg per kg in the same day.
Reduce it or decrease it accordingly.
Decrease according to your PTINA. Once you achieve the target PTINA, stop the infusion, stop the heparin, and you discharge the patient on oral anticoagulants with the targets of 2 to 2.5. Otherwise, you can go for the newer agents like
apixaban or rivaroxaban,
which doesn't need any monitoring or anything. If the immediate effect will be there, but only the cost factor is a concern.
So this patient was started on apixaban, 10 mg like BD for 7 days, followed by 5 mg BD. And if it is like rivaroxaban and all, it can be like 15 mg BD for 21 days, followed by 20 mg OD. Like that, single dose.
So how long you need to continue this thing, anticoagulation?
Anticoagulation, if it is like it is not like previously it was like provoked like that. If it is unprovoked thing, it should be like for 3 months. If it is like any active malignancy, anything is there, we can have to continue it. So basically, if the patient is having with any active malignancy, any Apla-like syndrome, any factor that is ongoing, risk for embolism, lifelong anticoagulation has to be continued. If it is because of a surgery, long flight, or fracture, trauma, and all those things, pregnancy, all those things, it can be like for 3 months or like 6 months, and then we can stop. And this patient, a CTPA was actually done for after stabilizing her. CTPA was done within 6 hours, which was showing a filling defect in the left main pulmonary artery extending into the lingular and lower segmental arterial branches, and also a subsegmental branch of right ascending pulmonary artery. Along with that, she had bilateral pneumonia-like features suggestive of a ground glassing, suggestive of a viral pneumonia, with a CT severity index for COVID pneumonia of 18 on 25. Her blood counts were showing a total count of around 33,000 with hemoglobin of 7.5 and platelet of 6 lakh. And the infective parameters are also checked for, because her Proccal was 0.9. So it was negative, and her CRP was 144, maybe secondary to pulmonary embolism, and leukocytosis also can be secondary to pulmonary embolism. But in view of the current situation, we have done a COVID test. So a gene expert test for COVID test was done, which came to be positive.
So again, there was another risk factors. We have
COVID,
underlying COVID,
pneumonia.
which precipitated an event.
And her D-dimer was 10, but it was 17, but it was like, obviously it will be like positive here. Other parameters were mostly with a
So
normal
what was
limit.
done for her COVID?
She was started on remdesivir, sir. Basically, she was given an antibiotic coverage she was started on piperacin and tazobactam, and also she was started on remdesivir 200 mg on the first day, followed IV first day, followed by 100 mg OD. And she's continued on that, and she is also on apixaban. But her current status is her oxygen requirement has come down to maintaining saturation of like around 95% with the 1 liter O2 by nasal bronch. Her like other hemodynamically, she is not on any inotropic supports currently, and like in a shifting of phases.
Okay. Anything, sir?
Okay.
Uh,
Okay. So suppose you don't have any risk factors, so you need to definitely look into the risk factors. Why she developed this? So you are not getting any cost. So then you need to work up for
Aplalix
Aplalix
syndrome,
syndrome
females,
also.
thrombophilia condition,
SLE, all these things.
then factor
Protein C,
5,
protein S
factor
deficiency,
5
all
laden
those things you need
mutation,
to have
all those
work.
things. And in males, it can be this homocystinemia
Homocysteine.
and all those things. Smoking and everything can lead to this.
And the other sides of thrombus, apart from it being in the top muscles, what are the other sides of thrombus?
Upper limb can be
Upper limb.
That is mostly like post surgery, breast surgery, and like there can be upper limb thrombosis can be there. Then pelvic inflammation, like pelvic vein thrombosis can be there.
Iliac,
Yeah,
brachial,
both the proximal leg veins and distal leg veins, there is chance of thrombosis.
Especially already had a vaccination or
She had one dose of
One
vaccine.